Okay, so I finally got around to compiling some questions and notes for pediatric immunology questions that we wanted to kind of look at to make sure we grasp everything. Quick note here, so depending on what the patient is presenting with, these are some key things that should come to your mind. So if a patient has a B cell immunodeficiency where they really can't make any antibodies, this deficiency usually doesn't affect the child until the antibodies they got through passive immunity from their mom, until that goes away. So they start classically getting symptoms at age 4 to 6 months or after 6 months when maternal antibodies disappear. Sinopulmonary infections caused by encapsulated bacteria are typical because although encapsulated bacteria were originally only really a problem for asplenic patients, here, although they have a spleen, they don't have the immunoglobulins they need to actually opsonize those encapsulated bacteria. So you're going to see those kinds of encapsulated bacteria infections after 6 months of age for most of those patients. T cell immunodeficiency. Now T cells you don't really get from mom that much. So here a presentation typically occurs in early infancy with severe bacterial, viral, and fungal opportunistic infections. And because they're getting all these infections ever since they're born, they also have a failure to thrive. Now imagine like a newborn constantly having diarrhea, they can't really grow that well. So failure to thrive is usually a big giveaway that there is involvement of T cell immunodeficiency. And they're also going to have an increased metabolic rate to try to fight off the infections they're getting, but of course they're going to fail because they're not equipped to actually try fighting those guys. Now, we looked at all the different diseases and stuff. We needed to revise this. This is from back in step 1, right? Differentiation of T cells, understanding how T cells actually go from the T cell precursor that is found in bone marrows. Of course, B cells and T cells both come from the bone marrow, but T cell precursors mature in the thymus, right? It's a T for thymus. They go to the cortex where positive selection occurs. So positive selection basically means getting one or the other, right? You're going to be either CD8 positive or CD4 positive. So that's your positive selection. And then in the medulla of the thymus, you get negative selection where you kill off any of these guys that have too much self affinity, right? If you don't kill off the T cells that have too much of an affinity for your own cells, then you're prone to autoimmune disease, right? And that's obviously never a good thing. After that, of course, your cytotoxic T cells or your CD8 positive T cells that go fight. Your helper T cells, CD4 positive T cells, can go ahead and then further differentiate into any of these things. And you can see the various signaling that is involved, right? So back in step 1, I came up with things to help memorize that. So over here you can see interferon gamma and interleukin 12 both give you Th1 helper T cells. So I wrote here interleukin 12 and interleukin 2. Right, remember that interleukin 12 and interleukin 2 both enhance natural killer cells. That's number 1 to remember. You have to keep that in mind. That gets asked a lot. For natural killer cells, what increases the activity of natural killer cells? Interleukin 12 and interleukin 2. This was used on step 1, and this is still something that you can get tested on CK. Now, here's the mnemonic for memorizing this stuff. So I wrote, use the idea that interleukin 12, the number 12 starts with a 1, so it actually upregulates Th1 formation, while interleukin 2 is a 2, so it upregulates Th2 formation. And you can see that, right? We all know it's not really theoretically going to be interleukin 1 here because interleukin 1 is from the hot T-bone mnemonic, hot T-bones, or hot T-bone steak. That's for the fever, interleukin 1. So that's not the key thing here, right? And then hot T, the T part is interleukin 2, so you can see how it starts kicking in. So interleukin 12 gives you Th1, interleukin 2 and 2 squared is 4. I wrote that here as well, 2 squared is 4. So again, they both, interleukin 2 and interleukin 4, give you Th2. And the opposite guys stop each other, so you never really need to make both of them. So you can see how if interleukin 4 is present and it makes Th2, right, then interleukin 4 also stops making Th1, right? So that kind of stuff. And of course, the 4 was the E in hot T-bone steak, so there's also more IgE. So, there's a bunch of ways to memorize these things. You use your best creativity and best recall to actually make sure you have this wording down, understanding the idea of being double positive, double negative over here, and then being, of course, singularly positive, which is the functional version of each of these guys. All of this is just terminology that can randomly be thrown at you in a question, and you have to be very careful in not messing up what you're reading there. And then, of course, those T cells are as we've seen back in step one, are critical for the interaction between B and T cells. So let's make sure we get that down too. Right here, right? So you have multiple signals between T and B cells to get B cell activation to occur. And there's two key ones that you need, two mandatory signals that are necessary for actual activity to take place. So any antigen presenting cell is going to pick up an antigen, show it on its MAC to your T cells, right? And you need both of these connections to occur over here. The antigen being presented to the T cell receptor, while the B7 from the antigen presenting cell being attached to the CD28, right? Both of those things need to occur. That T cell becomes activated and can now go ahead and further activate B cells, right? So you can see here they put signal 1, signal 2, right? Both of these things need to occur, and then this can occur. And when this occurs, you get IG class switching. So as we've seen in many of our immunodeficiencies, patients don't tend to have all the IGs they need. Like they might be deficient in IgG or IgM, whatever it might be. So you look for that in questions when they present it to you. Right? And then of course there's also potential issues where you can have someone missing B7 or missing CD28 or missing the CD40 ligand. Any of these things missing can also cause issues, and we're going to see the one where CD40 ligand is often missing. Remember that if a patient has CD40 ligand missing, they still have a bunch of T cells and they also have a bunch of B cells. It all just doesn't do what it needs to do. None of it works well, right? So it's all dysfunctional B and T cells. So now if we come back here, we start seeing right here B lymphocyte development, right? You have your B cell that gives you in the bone marrow it's made, and it matures in the bone marrow as well, unlike the thymus. Unlike the T cell. Right? So the B cell and T cells are both made in the bone marrow. T cells go to the thymus to become mature. B cells stay in the bone marrow to become mature, and then they go to the spleen where they're gonna go ahead and do their job as a mature B cell. All right, and from there, as necessary, whenever there's infection, they can migrate to lymphoid tissue anywhere depending on what the infection is and secrete antibodies to kill whatever the pathogen is. Here we're seeing something related to interferon gamma. Same thing again, we have our T cell or a natural killer cell, right? They can secrete interferon gamma in response to interleukin 12 secretion to actually make these macrophages kill what they need to kill, right? Enhance intracellular killing. So interferon gamma is one of your big things for macrophage. The macrophage and gamma both have a G in it, so you need to make sure you associate the two guys together. They are completely irrelevant. Interferon gamma completely irrelevant to interferon alpha and beta, which are actually guys that interfere with viral protein replication. So that's different. Those guys are for a whole different set of issues. Interferon gamma is the one that helps macrophages actually kill things. Here we have three questions that are all related to the same thing. They present the topic in slightly different ways, so you get to see three different ways of presenting Bruton's X-linked A-gamma globulinemia. So now, just for quick revision, that was a BTK gene mutation, or Bruton tyrosine kinase gene mutation, resulting in defective Bruton tyrosine kinase. So you end up having impaired B cell maturation and immunoglobulin production. So your B cell will not mature. That means you lose the rest of this over here, right? Now, what do you get because of this issue? Well, you're going to get recurrent sinopulmonary and GIT infections after usually age 6 months. Okay, that's what they're going to do for questions for the most part. They might come down to 5 months, but most times after 6 months of age. You get chronic enteroviral infection as well, and you can have small or absent lymphoid tissue like tonsils, adenoids, because they don't actually make most of their lymphoid stuff that they need to, right? Lab findings are going to show you low immunoglobulins and antibody response to vaccines, right? So remember, there's no point in they can get vaccines. They'll be given vaccines, but it just won't work. It'll be ineffective because they won't make antibodies. And because of that, most times you probably don't even want to give them vaccines once you figure out that they have agammaglobulinemia. And treatment is very simple, straightforward: IVIG for life, and prophylactic antibiotics to save them from infection as necessary. So now let's take a look at these three questions to see what happens to these people. First one here: 3-year-old boy brought to the ED for 2 days of fever, cough, and worsening shortness of breath. Right. His parents report he recently recovered from a prolonged diarrhea due to giardia. Medical history is significant for recurrent ear infections treated with antibiotics since age 6 months, and lobar pneumonia requiring hospitalization. Today, his vitals are clearly showing he's got infection. Physical exam reveals small tonsils, right? Because he doesn't have tonsillar or all those. That's the point right here. Small tonsils or adenoids, and crackles in the lower lobe of the right lung. His weight is in the 40th percentile, which means that developmentally he's good. Remember that percentiles are only of concern when it's below 15th or above the 85th. So this is average growth, so that's good. What is the most likely cause of his recurrent infections? Straightforward: abnormal B lymphocyte maturation. His recurrent pneumonias, giardia infection, and small tonsils are all suggestive of BXLA, Bruton's X-linked agammaglobulinemia, a defect in the BTK gene resulting in abnormal B cell maturation. Low B cell concentrations lead to smaller absent lymphoid tissue and very low serum immunoglobulin concentrations. Due to impaired humoral immunity, infants with XLA are predisposed to recurrent silent pulmonary infections with encapsulated organisms like H. influenzae and S. pneumoniae. The absence of IgA, because they can't make any of them, so no IgG, IgE, any of that, so no IgA either. The absence of IgA increases the risk of luminal infections like in the GIT with giardia. Infections accumulate after the age of 6 months when maternally acquired IgG begins to wane. So you just treat with replacement of the Ig and prophylactic antibiotics. Very straightforward question. Notice how though they started the question with a 3-year-old boy. Okay, age is going to be a huge thing in this chapter, I guess. Immunology, especially pediatric immunology. So be very keen on figuring out where issues first started presenting, not the age at which the patient is coming in. Right? And the fact that he's not dead yet and that his growth has been pretty good also helps leading you towards that this is X-linked agammaglobulinemia and not one of the other issues. The lack of certain symptoms also helps you figure out this is X-linked agammaglobulinemia and not one of the other things, because those things would have some other symptoms, as we'll see. And lastly, because it's a boy, right? X-linked agammaglobulinemia is mainly going to occur in boys. Now, right here, literally same question again in UWorld, but now they changed a few things around and the answer was different. So a 3-year-old boy is brought to the emergency department due to fever and respiratory distress. Medical history includes recurrent otitis media and hospitalization for pneumonia. Immunizations are up to date. Height and weight are good, 40th percentile. Vitals are showing that he has infection because of his fever. He's drooling and has marked stridor. Emergency intubation is performed and an inflamed epiglottis is noted. Antibiotics are administered. Blood cultures show Haemophilus influenza B. Labs show deficient serum-specific antibody titers to tetanus, diphtheria, and HIB, and pneumococcus. So although he's got his vaccinations, right, immunizations are up to date, he doesn't have antibodies. He didn't make any antibodies, so the vaccinations were ineffective. What additional testing is indicated? Well, you should have been able to figure out by that point that this is also BXLA, so you would need to do flow cytometry. That's how you diagnose this. Flow cytometry of peripheral blood. This patient has BXLA. Characteristic lab findings are low levels of all immunoglobulins as well as deficient antibody response to vaccines, like in him. Flow cytometry will show reduced CD19 positive B cells, and then of course genetic testing will confirm the diagnosis, where you'll see the X-linked issue. All right, so flow cytometry is a big, or the only real way of doing a lab test for this, and then you rule it in with a more specific test, which is the genetic testing. Now here is the last one for X-linked agammaglobulinemia. So now we have a 15-month-old boy is brought to the emergency department due to irritability and vomiting. His parents say that he was more tired than usual yesterday and went to bed early. This morning he awoke crying and has been inconsolable. His mom attempted to feed him, but he has vomited twice today. 3 weeks ago, he had similar symptoms and was admitted to the hospital and diagnosed with enteroviral meningitis. He has a history of 2 episodes of pneumonia requiring hospitalization as an infant. Temperature is very high today. On exam, he's awake but crying and inconsolable in his mom's arm because of his crazy high fever. Heart and lung exams are fine. Abdomen is soft. There's diffuse macular rash over the trunk. Lumbar puncture reveals the following. So CSF, glucose 50, protein 80, leukocytes 300, red blood cell 5. So this is supposed to show you that this is a viral profile, because the glucose is normal. Remember, if glucose is low, then you start thinking something alive is in there, like a bacteria or a fungus. But if glucose is normal, then it must be something that's not really alive, like a virus thing, a viral thing. Protein is 80, and then leukocytes 300. So all that going together, the white blood cell being between 10 to 500 also further indicates that this is someone who has a viral infection. I believe this was supposed to be 40 to 185. Yeah, protein. So the protein count here is also considered normal. And now, furthermore, they look at the gram stains. Gram stain reveals no organisms. He's suspected to have chronic viral meningitis. What additional findings are most likely to be seen in him? Okay, so you can see the same kind of thing again, but now they're focusing on different infections. They're trying to throw you off by picking on this aspect of meningitis, but there's no reason meningitis can't occur, right? So that's just another option that something can occur, and you just have to work with it. But other than that, everything else fits. It's a boy, so it's okay to be X-linked. Symptoms started, where did they say when it started? 2 episodes required as an infant, so anytime after 6 months fits, right, as an infant. And then other than that, the lack of any other symptoms that would make you think of anything else takes you correctly towards the idea that this must be Bruton's X-linked agammaglobulinemia. But 30% of people chose the answer choice of absence of interferon gamma receptors. He has chronic enteroviral meningitis and recurrent pneumonia, which are features of BXLA. Sinopulmonary infections are most common, and patients are predisposed to chronic enteroviral infections. Prolonged diarrheal illness due to low IgA can also be seen. So it all fits together. But interferon gamma, which we have right here, the intracellular killing of mycobacteria is what's activated by interferon gamma, the macrophages. The interferon gamma interacts with the receptors on macrophages. Deficiency results in disseminated mycobacterial infection, which is not what this kid has. All right, so that's the story there. Let me see something real quick. From that, we're also okay. So IgA deficiency is one of the easiest, straightforward questions, so you don't need to worry about this too much. This is going to be someone who only has luminal infections, So all they get is a lot of things in the lumen of the respiratory system and the GIT, but not necessarily respiratory, meaning that it's pneumonia. It's not that the infection goes into the lungs, but the lumen being more so like the sinus, the trachea, stuff like that, right? Of course, it could reach the lungs, but it wouldn't be that problematic. IgA is secretory IgA, is protective, so these guys won't have anything else besides the respiratory and diarrhea stuff. And they'll be much older too. They don't have to be super young to get these issues. Okay. Most confusing question they can try asking you is the severe allergic reaction from giving them any blood products that have IgA in it, so you avoid that. Common variable immunodeficiency though is a little harder. The only difference between Bruton and common, the biggest difference is the age. They present very similarly, but much older, right? These are literally like possibly adults. So very similar presentation, whether it's Bruton's agammaglobulinemia or common variable immunodeficiency, but this guy is much older, so we're going to see that in a question soon too. And then hyper IgM syndrome, what happens here is they, again, very similar to BXLA, they also don't have any other Ig except IgM. They can only make IgM. So either the question will tell you they have super high levels of IgM, or they'll need to tell you that something's wrong with the CD40 ligand that we just looked at. Right? This CD40 ligand is missing. So without the CD40 ligand, you can't do Ig class switching. Okay, so it's a problem on T cells. The T cells are missing CD40 ligand. right? But here they list it as a B cell disorder because your B cell is unable to do class switching. But your B cell does have a CD40. In my opinion, that's a little unfair to say that it's a B cell disorder when the B cell is actually okay. The B cell just can't do its job because the T cell has a disorder. CD40 ligand is not working. So we're going to see that in a question soon too, starting from here. Alright, so let me see what this is. Oh, that was Kawasaki. Okay. So first question we have here, hyper IgM syndrome. 14-month-old boy is admitted to the hospital for treatment of pneumonia. Alright, so still, so far this first sentence fits BXLA or hyper IgM. Either one is possible right now. He has a fever, cough, and labored breathing, 3 episodes of bronchiolitis during infancy, and an episode of pneumococcal pneumonia 2 months ago that required intubation and hospitalization in the ICU. He also has a history of recurrent otitis media. He takes no meds and vaccinations are up to date. Weight is 15 pounds, which is in the 3rd percentile. Really not growing well at all, right? He has fever. On exam, he appears listless and is in mild respiratory distress. Bilateral ear canals contain purulent drainage, so there's infection in the ear. Crackles are heard in the left lung base, and the labs show you high leukocytes, of which 75% are lymphocytes. Okay, then they have immunoglobulin counts, so they tell you IgG is low, right? Because normal is 673 to 851. Now these numbers are very accurate and specific. You don't need it like that. You can come up with your own ranges that you can better memorize, like 680 to 850 or 650 to 850, anything like that. Because if it's going to be low, it's going to be significantly low, not just like a little low. For example, in a question, they're not going to tell you IgG is 660 because that's not theoretically low. I mean, technically speaking, it's low, but 660 isn't so bad. That just means that he just needs to make a little bit more, right? So it's very low, IgG. IgA is also low. IgM is high. And then the CD4 to CD8 ratio is 2.2, which is also normal. That means he's making T cells. So in this question, as you can see, had they not told you that he has super high IgM levels, you wouldn't have difficulty picking hyper IgM syndrome as an answer choice. Right? If they didn't tell you that, then they would have to tell you something that makes you think of the fact that the CD40 ligand must be missing. But again, they don't have that either in the question. So that being said, this hopefully will continue to be a very easy question where they tell you something key that gives you the diagnosis, right? Although frequent mild respiratory infections are common in childhood, although frequent mild respiratory infections are common in childhood, this patient has severe recurrent pulmonary infections leading to intubation, tympanic membrane perforation, and poor growth. These findings are key for a primary immunodeficiency. In the setting of low IgA and IgG and markedly high IgM, the most likely cause is hyper IgM syndrome. It is an X-linked recessive defect in the CD40 ligand, which hinders T cell binding with CD40 on B cells, which would induce B cell class switching. Although they are dysfunctional, B and T cell concentrations are normal and lymphocytosis can occur during infection. Neutropenia is also common, right? They don't have that many neutrophils, but it is there, but most of it is all lymphocytes because they can't actually convert things. There's no CD40 ligand to make the connection occur. Right, so lymphocytes means that they have a lot of T lymphocytes and a lot of B lymphocytes, but they're unable to actually activate the lymphocytes into turning things on, releasing cytokines, doing Ig class switching that can then go ahead and turn on natural killer cells and all neutrophils and all that to go fight shit. Recurrent pulmonary infections by encapsulated bacteria is the main finding. Patients have frequent viral infections and an increased risk of opportunistic Girovechi infection due to lack of T cell interaction with antigen-presenting cells. Treat with antibiotic prophylaxis and IVIG. If anything makes this a little more different than the others, it is the. Let me just go back and look at it real quick. Yeah, it's generally the T cell stuff. Remember in X-linked agammaglobulinemia, they're just missing this. They don't have this, but they do have this, right? They have their T cells, so they're not really gonna get infection from some of those T cell specific issues. Remember the T cell specific issues we just looked at up here, right? That loss of T cells will lead to getting opportunistic fungal infections and viral infections, that wasn't really what's happening with Bruton's agammaglobulinemia. The type of infection present is very critical, and these guys are not getting opportunistic viral and fungal infections. As you can see from all three infections, the only thing that they got was Giardia, simply because they don't have IgA, so that makes sense, right? But other than that, most of the questions on agammaglobulinemia are pretty straightforward and simple, very similar looking. Here, though, this kid, you know, could get viral infections with opportunistic P. or many other random things that you wouldn't see in X-linked agammaglobulinemia. So if you see more questions, you'll start seeing that the type of infection they get is very critical. They didn't really focus on the type of infection too much because they gave you the IgM count to make the question a little easier. All right, so that's your CD40 ligand deficiency. B cell count normal, but they can't really do anything. All right, IgG low, IgA low, IgE is low. The B cells are able to make IgM, and that's all they keep making because they can't do class switching since they're unable to connect with the T cells. You need that signal number 2 to actually connect with CD40 ligand to go ahead and make the other guys. All right. Then we have this question here. This one is for SCID, severe combined immunodeficiency, which is really, really bad. This child will probably die if not treated with stem cell transplant quick enough. Severe combined immunodeficiency. 1-year-old boy is admitted to the ICU for severe respiratory distress and hypoxia requiring endotracheal intubation and mechanical ventilation. Medical history shows 2 prior episodes of pneumonia, and up to there, it was all looking a lot like BXLA until now. Now they'll say the kid also has chronic thrush. That's candidiasis. That's fungal, right? And then tympanostomy tube placement for recurrent otitis media. The chronic thrush part rules out X-linked agammaglobulinemia as an answer choice, and now you start thinking of other things. His vaccinations are not fully up to date due to illness at the time of his well visits. He is at the 2nd percentile for height and weight, so he's not developing very well at all. Physical exam shows diffuse crackles in both lungs. Labs show low CD19 and CD3, so that's a giveaway, right? CD19 means no B cells, CD3 means no T cells. He also has low immunoglobulins but normal IgA levels. What is the best long-term treatment for him? Stem cell transplant. There's also no real chance of rejection either here because they don't really have much of an immune system, so the transplant just works out fine. He has recurrent and severe infections, failure to thrive, and lymphopenia. These findings are consistent with SCID, a severe primary immunodeficiency. Without cellular immunity, patients are at high risk of viral, fungal, and opportunistic infections. No more T cells. The loss of helper T cell also causes B cell dysfunction because then you don't have that connection with the CD40 ligand and CD40 on B cells, leading to impaired humoral immunity as well, which causes recurrent sinopulmonary bacterial infections. Failure to thrive and chronic diarrhea are typical. Stem cell transplant is the only definitive therapy and should be performed ASAP, otherwise SCID is fatal in childhood. So if you got a patient who's a 3-year-old and they have certain issues, the answer is not SCID. You can see how age is really going to help you as well as gender. This was a very unique question on something specific, transient hypogammaglobulinemia of infancy. 7-month-old boy is brought to the clinic due to concerns for frequent infections. He has had 2 episodes of acute otitis media in the past month. He is developing normally and has received all age-appropriate vaccinations. Height and weight are at the 65th percentile. Cardiopulmonary exam is unremarkable. The abdomen is soft and non-tender with no hepatosplenomegaly. There are red, scaly lesions over the cheeks bilaterally with some surrounding excoriations. Labs show you high leukocytes, right? Immunoglobulins, again, you're seeing the numbers, right? So IgG is low, IgA is normal, IgM is also normal. Tetanus IgG and diphtheria IgG are also present. What is the most likely diagnosis? So now all of a sudden everything feels a little weird, okay? Remember that these numbers, by the way, do shift. They do shift because what's normal depends on the age you're at. So theoretically speaking, you're not required to memorize this. You don't need to memorize the normal levels. Like, you're not really required to memorize any of the labs or whatever. Some, they're usually given to you, but memorizing electrolytes, what's the normal amount for electrolytes, like potassium is normal 3.5 to 5, those kinds of things, really helps speed up how quickly you get through questions, so you should memorize those. But this you don't have to memorize, so don't worry about that. They're going to have to give this to you if they want you to use this, because the normal levels change based on the month. right? How old the baby is. So for this baby, just slightly lower IgG, right? It's not that low. In fact, you could tell even the normal isn't supposed to be that high to begin with. And IgA is normal, IgM is normal. Everything seems somewhat normal. Also has antibodies to the vaccines he got. So this patient, the scenario for this patient doesn't really fit any of your immunodeficiencies. So when you see a weird answer choice like transient hypogammaglobulinemia of infancy, you reevaluate the question to see if it does really fit that answer choice, because it definitely didn't fit what 20% of people chose was Wiskott-Aldrich syndrome. Remember, Wiskott-Aldrich was the WASP pneumonia, WASP, and it makes your platelets look like wasps, tiny platelets, or basically not having platelets, but he has platelets, normal level of platelets between 150 to 400K. And then the 10% of people that chose BXLA, this isn't BXLA. BXLA, you wouldn't have antibodies to the vaccination you got. The vaccine would be ineffective, right? So it was a very good, easy question. The only thing that made it slightly harder was the fact that it was about a topic that's not in the book. But that's okay, because the topics that are in the book are not in the question, right? It goes both ways. Is the question topic in your book? Then you don't know about the topic if it's not in the book, sure. But then the other answer choices, if your book has those answer choices, then you should be able to figure out that that is not what the question is about, right? So it goes both ways. So you should be able to rule out wrong answer choices because you studied them, and then see if your only remaining answer fits the scenario at all. And it clearly does. It clearly does. It looks like in another month or so, the IgG levels will also catch up and everything's going to be okay, because he's doing fine. Having what he has right now is just normal. You get acute otitis media. It happens in infancy. Ear infections, we've all probably gotten it. No big deal. All right. So that was related to this, and they used the term nadir again. Remember, nadir was also a term being used constantly in obstetrics. Physiologic nadir is right here, where it's really just so close to continuing on to becoming normal, right? It's just it's a point where you see the maternal IgG was there. It started waning away, right? The maternal IgG has started waning away. That's the dotted line that's going down. But the child's own IgG formation has started beginning. So in this little period right here where the two things are trying to catch up, there's a deficiency in IgG levels. That's it. It's just transient. It'll last maybe a month or two, and then they should be back to having normal levels of immunoglobulins. Last question here. This one is regarding the topic of CGD, chronic granulomatous disease. Remember, in CGD, it's an X-linked, so which means it'll be common in boys again, recessive mutation in NADPH oxidase, which impairs the respiratory burst. So now you can't kill anything that's catalase positive, because they can neutralize all their own reactive oxidant species, so they don't really get attacked by anything. You need NADPH oxidase to kill them, right? So you get recurrent infections with catalase positive bacteria and fungi, and you're going to see that in this question. So 2-year-old boy is admitted to the pediatric unit for treatment of a large abscess, and that's the key term. Abscess is the key term to make you think of CGD. He has been treated for 2 other skin abscesses with purulent drainage in the past. One culture was positive for Staph aureus, which is catalase positive. He has 1 prior hospitalization for pneumonia with pneumonia with empyema. He was born at full term via spontaneous vaginal delivery after an uncomplicated pregnancy. Height and weight are at the 5th percentile, so not really developing that well at all. He takes no medications. Immunizations are up to date. His dad has diabetes. His brother died at age 3 months from Serratia infection, which is also, I believe, catalase positive. And his mom and sister are in good health. Let me just check that real quick. Yeah, Serratia is gram-negative, catalase positive, oxidase negative, right? So again, most people wouldn't really know Serratia is catalase positive, but it's, like, first you would have to understand, when you're reading this question, that when you saw the word abscess, you would think of CGD, and then if you thought of CGD, then you would think, okay, it's not so far-fetched to think Serratia may be catalase positive, and that's what killed the brother, because this is X-linked. Mom and sister are fine because it's X-linked. It only goes to the, it's X-linked recessive, so it only, affects the sons. That's it. And also understand that when it's an X-linked recessive disease, all the sons are getting it from the mom, not the dad. The dad gives the Y chromosome to all the sons, and the dad gives the daughters an X chromosome, right? But the daughters are going to be okay because daughters have two X chromosomes, so it's actually recessive. The good X chromosome will give them whatever they needed. They go on to say he has he has high fever today. Eyes, ears, nose, and throat are normal. No lymphadenopathy. S1 and S2 are normal. No murmurs. Lungs are clear. No hepatosplenomegaly. 4x4 fluctuant area of erythema and induration is present on the right thigh. No rashes. So again, the only thing this kid really has is really bad abscesses today, right? Or history of abscesses, with one thing about pneumonia here, which can also be abscess. And all of these things seem like catalase positive is related to it. So this patient has recurrent skin abscesses, SRS infection, and failure to thrive. A male sibling died from serratia infection as well. This presentation suggests X-linked immunodeficiency since it's primarily affecting male patients, and it is most likely CGD, which involves abnormalities of the NADPH oxidase enzyme, which is responsible for the respiratory burst to form superoxide radicals. Patients have decreased production of superoxide anions, so phagocytes migrate to and surround the infection sites, but are unable to actually kill the organism, so you get an abscess, which is why anytime you get a question where it's all about the abscess, you really want to consider CGD suspicion. Diagnosis is made by the dihydrorhodamine 123 test or the nitroblue tetrazolium test. There is no specific treatment for CGD, and management is focused on infection prevention. That's it. Right. Also, to revise real quick, just telling you that it's those two tests, how you diagnose this is not enough. You need to know what the test is going to look like. So they tell you here that it's failure of those tests, right? So abnormal dihydrorhodamine, which means no green occurring, okay? And abnormal nitroblue means no blue occurring, fails to turn blue, okay? They could word it like that in the question for you too, and then you may not know what's happening. So if they don't tell you, oh, it didn't turn blue, then, or if they tell you, oh, the nitroblue tetrazolium test did not turn blue, then what does that mean? Well, it means it failed, and that means that it is CGD. That's kind of what you want to consider there, right? Same thing with the dihydrorhodamine test. Not giving you a green response means that it's a failed test, which means that this is CGD. Okay, those two tests actually search for the superoxide mutation, the superoxide formation occurring, right? That's what those two tests look for. They look for the respiratory burst. When they don't find the respiratory burst, they don't turn blue or green as they need to turn, which is a hint for you to understand that the patient has CGD. Right? This is just another summary thing right there. And then a few more questions regarding all the topics we're looking at. So now, there were a few more things here, right? Then you had your pediatric phagocytic deficiencies regarding the phagocyte not working with macrophages, right? So you have CGD, which we just looked at, LAD, Chidiac-Higashi syndrome, and then hyper IgE job syndrome. I have yet to find any good job syndrome question, but it's a pretty straightforward thing with these weird things. Here you're also going to get abscesses. Remember, abscesses are pretty much going to be in most of these because it is a problem with phagocytes not working, but mainly the abscess is going to be a CGD thing. Here you're going to get an abscess, but you're also going to get some other weird things like atopic issues like eczema or retained primary teeth, or they might tell you that there's a high level of IgE. So those things will give you job syndrome. Let's look at this question right here. 14-month-old boy is brought to the office for follow-up due to pneumonia. He required hospitalization 2 weeks ago for lobar pneumonia. His second admission for this diagnosis in the past. His second admission for this diagnosis in the past 6 months. A chest tube was placed for an infusion with a pleural fluid demonstrating minimal leukocytes and numerous gram-positive cocci in clusters. The fever resolved after 10 days, after which he was discharged, although he continues to have cough and occasional increased work of breathing. This slow symptom improvement also occurred with an episode of non-purulent staphylococcal cellulitis last month. So the cellulitis is pretty different here, right, as opposed to BXLA. So that helps you not really think of BXLA anymore, because up to that point it was kind of sort of fitting BXLA. This slow symptom improvement occurred with cellulitis. Today, temperature is 100 F. Oral exam reveals eruption of both upper central incisors with surrounding erythema and ulceration. Also weird, right? Why does he have eruption of his upper central incisors with an ulceration and erythema? That's pretty different from everything we've seen so far. Posterior oropharynx appears unremarkable. Lung sounds are diminished in the left lower base with some scattered crackles. Heart sounds are normal. The abdomen is soft and non-distended without hepatosplenomegaly. The remainder of the exam is fine. Okay. Then they give you some labs where you're seeing that 70,000 leukocytes with 90% neutrophils, and that's 90% neutrophils. Doesn't matter what the rest are. 90% of his shit are all neutrophils. So if he has all these neutrophils, you wonder then, right? If he has all these neutrophils, why are they not going to where the infection is and just kill it? That's what you should think there. They also tell you that his lactate dehydrogenase is 80 and CRP is 45, which is a sign of inflammation. But 45 is not really, I'm not sure how indicative that is for a 14-month-old child. Either way, they continue to say chest x-ray reveals a pacification of the left lower lobe and a small effusion improved from 2 weeks ago. What is most likely present in him? So the answer was reduced CD18 markers on surfaces of neutrophils. 55% of people correctly identified that. 20% of people chose giant granules within neutrophils, which would be Chidiac-Higashi syndrome. This patient with recurrent non-purulent infections and marked neutrophilia most likely has leukocyte adhesion deficiency, an autosomal recessive disorder characterized by reduced CD18 antigen on neutrophil surfaces. CD18 is a key component of integrins, which are required for neutrophil migration through vascular endothelium to the site of infection. Since the skin and oral mucosa are susceptible to bacterial invasion, LAD classically causes recurrent skin and mucosal infections, hence why he has the cellulitis and the gingival ulceration. GIT and respiratory involvement may also occur. Infections may be prolonged and are often life-threatening. Because neutrophils cannot travel to the site of infection, the absence of purulence is typical, and infectious fluid lacks leukocytes. Other characteristic features of LAD include impaired wound healing, which can manifest as delayed separation of the umbilical cord, which they're probably not going to give you in a question because it'd be an easy giveaway, and delayed wound healing after surgery or trauma. The most common pathogens are S. aureus and gram-negative bacilli. All right, so again, pretty unique presentation. This one also is LAD deficiency. So here is a 3-year-old girl. Right, so different age group now. We had a 14-month-old boy here. Now we have a 3-year-old girl for this question. 3-year-old girl is brought to the emergency department due to severe oral pain that began 2 weeks ago with discomfort while chewing. It has progressively worsened, and now she refuses any oral intake. She had a similar episode of oral pain last year. Medical history includes 2 sinus infections and numerous episodes of non-purulent cellulitis. So we're seeing a similar thing again, right? Cellulitis and oral pain. There was oral ulceration in the previous guy. Skin cultures from previous infections isolated S. aureus and S. pyogenes. Physical exam shows periodontal inflammation with ulceration and necrosis. Once again, her leukocyte count is also showing you super high neutrophils, but for some reason the neutrophils are not going where they need to go. So that's defective leukocyte adhesion. Very straightforward. Different from everything else we've looked at. You study the question, you understand what's presenting in the question, and you get it. Now, this question, I believe a couple of these are CVID. All 3 of these are CVID, right? So let's see what's happening with them. They're all different too. There's a 14-year-old boy, a 32-year-old woman, and a 12-year-old girl. Okay, that's because, as we saw, CVID all the way up here, right after BXLA, CVID is very similar to BXLA, except there's also missing T cells, and it occurs in more grown-up patients, not newborns or anything like that. All right, more grown-up patients are being affected right there. So let's go take a look at those questions, see what's happening. First one, 14-year-old boy is brought to the clinic due to severe left ear pain. Medical history includes several episodes of acute otitis media as a toddler. Each infection resolved properly with antibiotics. Over the last 3 years, he has developed recurrent acute otitis media, often complicated by sinusitis. Last year, he missed 2 weeks of school due to an episode of pneumonia. Vitals are fine. Exam shows an erythematous and bulging left tympanic membrane. IG testing reveals IgM is normal, right? On the lower end, but normal. IgG low, and IgA also low. Okay. Vaccinations are up to date, but titers for tetanus, diphtheria, and pneumococcus are low. What is the most likely defect present in this patient? So you can see how this question kind of sort of has, a lot of overlap with BXLA. However, you wouldn't really pick BXLA because it's a 14-year-old boy, not a 2-year-old boy. And if he made it to age 14 and he's doing pretty good overall, then this must be common variable immunodeficiency, all right? And the answer was impaired differentiation of mature B cells. That's the pathophysiology or the pathomechanism of how CVID works. This patient with recurrent sinus and ear infections, low Ig levels, and a low antibody response to vaccines has a primary humoral immunodeficiency, and it's most likely CVID, where B cells cannot differentiate into plasma cells. CVID commonly presents in adulthood with recurrent sinopulmonary infections caused by encapsulated bacteria due to a lack of antibody opsonization. Recurrent GIT infections can also occur due to low IgA. Patients may have atopic or autoimmune conditions. This could not be XLA since he did have ear infections as a toddler. This couldn't be XLA since he did have ear infections as a toddler. That's normal for many infants. He has been fine otherwise most of his childhood, and no family history is mentioned. Right? So again, just because of the early infections he had, and then today he has these infections, doesn't mean it's BXLA. Right? Other things have to be mentioned to help you figure it out. Otherwise, something else may be a better, more plausible, more likely answer choice. All right. That becomes even more evident here. 32-year-old woman comes to the office due to persistent cough and SOB. So there's no way you're thinking BXLA here because it's an older person and it's a female. But it's a pretty young woman, 32-year-old, right? Not like 90 or 70. She has had 3 episodes of pneumonia over the last 3 years. Okay, so since she was 29 maybe. She had severe sinusitis a year ago and an episode of bloody diarrhea that required hospitalization 6 months ago. Oof. She usually responds to antibiotics but takes several days to clear the infection. No other family members have similar problems. She has not traveled outside the US and does not smoke, drink, or do drugs. Neither is she taking any medications. All her immunizations are up to date. Vitals are fine. Physical exam reveals fine crackles over the right lower lung field. No lower extremity is present. No lower extremity edema is present. Neck palpation does not show lymphadenopathy. Her leukocyte count is 14,000 and she doesn't have HIV. Chest x-ray shows a right lower lobe infiltrate. What is most likely to reveal the cause of her underlying disease process? So again, this question was like a checklist of symptoms and issues and whatever is okay. And the answer here was just to do a quantitative measurement of serum Ig levels. Even if you didn't figure out this was CVID, that was the correct step to take. Right? Check how her immunoglobulin development is going. Is she making immunoglobulins or not? This patient with evidence of acute pneumonia, a recent history of recurrent pneumonia, sinusitis, and bloody diarrhea likely has common variable immune deficiency. A collective diagnosis can't stop the yawns. Collective diagnosis that includes a number of genetic defects resulting in impaired B cell differentiation and hypogammaglobulinemia. Right. So again, this topic is only different primarily based off of the age, gender, and general presentation that's occurring. But overall, there's a lot of overlap with BXLA here as well. Last question for CVID. 12-year-old girl is brought to the office due to nasal congestion for the past 2 weeks. Nasal discharge has become thick and green, and fever started today. On physical exam, she has mucopurulent nasal drip and tenderness over the maxillae. The remainder of the exam is normal. Medical history includes 2 prolonged episodes of sinusitis this year and a recent episode of giardia. She was hospitalized last year for S. pneumoniae. Prior to this, she was in good health. She has had asthma since age 3, but takes no meds other than bronchodilators as needed. Developmental milestones were fine. Immunizations are up to date. Height and weight are behind. She's not growing well. Diagnosis of acute sinusitis is made and antibiotics are initiated. what is important in her long-term management, and that's going to be IVIG. She just needs immunoglobulins. See, once again, this question also very much overlap with BXLA, except it's a girl and it's someone older. Right? BXLA would present much earlier and only in men, only in little boys. Okay, so that's the general concept of all that stuff. Again, you gotta keep doing more practice questions. Gotta knock all that out of the way. Get it down as perfectly as you can, right? And then once you're done with all that, you move on to the next thing. So we'll continue with neurologic disease later tonight at the 6 p.m. session. For now, go back once again, revise those immunodeficiencies, get it down correctly, know how to differentiate all of them. You don't want to get those questions wrong. They're supposed to also be easy giveaways. Just feel confident. And any immunology basics that you forgot from back in step 1, go back and revise it. Go back and get it down, because you never know what you're going to get asked in CK. Alright, so thanks a lot for joining, and I'll see you guys again at the 6 p.m. session.